Thank you, MedSynapse. Let me just introduce briefly about myself. My full name is Raja Affendi Raja Ali. I'm a consultant gastroenterologist, hepatologist, internal medicine at the University Kebangsaan UKM Medical Center since 2013 until today, and currently also hold the position as a Dean of the Medical Faculty of the University Kebangsaan Malaysia UKM here. I was trained in a medical school in Ireland back in 1994 as an undergraduate student, and completed my medical degree and pursued to higher medical training in the Royal College of Physicians in Ireland, and also do the specialist registrar training program in internal medicine, gastroenterology and hepatology. Then subsequently also do the Master of Medical Science in Gastroenterology, as well as a doctorate in medicine, focusing in the disease, inflammatory bowel disease, how this disease, IBD, can change to cancer. These are my research interests. I'm the fellow for the Royal College of Physicians in Edinburgh, as well as American Gastroenterological Association fellow. And I was elected to join the World Endoscopy Organization Emerging Stars program in 2018 and 19. Was trained to deep dive in the soft skill. I will not say soft, it's a hard skill actually, in managing day-to-day clinical practice, especially human management. And I also completed virtual training in the by the Oxford Executive Leadership Program recently last year. So my work as a clinician in the gastroenterology, predominantly focusing in the aspect of the inflammatory bowel disease. That is my niche for the gastroenterology. Yeah, that's all. Thank you. Thank you. Digestive tract or gastroenterology is always a field that I would like to specialize in when I started to become a student at year 3 many years ago. The reason why is a combination of not only the hands-on using endoscopy or many toys to diagnose, but also involving as usual consultation, physical examination, but also the component of histological examination involving analyzing the tissues, look at under microscope and various immunohistochemistry or markers. Now, gastroenterology, I think I mentioned to you early on, if you believe Hippocrates mentioned that all the diseases begin from the gut. And we all know that gastrointestinal tube or system are huge system. For example, the small bowel alone is about 7 meters long, and large intestine is about 1.5 meters. So the digestive tract is huge, and the unique things about the digestive tract is that they are occupied by the trillions of microorganisms. They are our little friends living in our ecosystem of different behavior or based on diet or geographical location where we live in, or even the way that the mother breastfeed or not the child would influence this community of the gut microbiota or microorganism. And I think the issue of any pathology or any diseases in the digestive tract is it could be from ourselves. For example, overeating. Yeah, we all know the stomach capacity, let's say, can accommodate about 2 or 2.5 liters or so. If we overdrink or overeat with plus the non-healthy food, and how this process can disturb the population or composition of the gut microbiota, and also can trigger many diseases, whether it is inflammation, cancers, or ulceration, neoplasia, many aspects, or even infectious diseases. So I think gastroenterology gives me the opportunity to study the huge surface area in the human anatomy. And I need to combine the skill, for example, endoscopy skill, to assess or to catch the sample to be diagnosed under microscope. And then with the symptoms and combination of endoscopy, biopsy, perhaps radiological markers, then we can make the diagnosis of the certain diseases before the treatment can be instituted in diseases. So there are various, Dr. Swastik, ranging from inflammation to cancer, pathology, from mouth to anus, basically, the whole digestive tract. That's the introduction, I suppose. All of us must know the diagnostic criteria for irritable bowel syndrome. So this criteria has evolved for years. So if I look at the most up-to-date about the diagnostic criteria for irritable bowel syndrome, all of us, my colleagues everywhere in the world, using what we call the Rome-4 criteria. In other words, the patient must have, for example, a recurrent abdominal pain for at least 1 day per week in the past 3 months. And this pain is associated with 2 or more of these features. For example, they can be related to defecation. They can be associated with the change of the frequency and the form or appearance of the stool. So one to really have to know this diagnostic criteria of the disease called irritable bowel syndrome very carefully, not just simple labeling the patient with IBS without doing diagnostic criteria. And to make the matter worse, that IBS also can be subcategorized either IBS constipation predominant, or IBS diarrhea predominant, or IBS mixed or bloated, where they got a big constipation, a big diarrhea, and bloated so and so. So we have to be very careful using the terminology or diagnostic element when we talk about irritable bowel syndrome. When you mention about Crohn's and ulcerative colitis, these 2 diseases are the spectrum of inflammatory bowel disease, IBD. And IBD is not equal to IBS. So IBD, let me define, is a chronic relapsing remitting of inflammation in the bowel of unknown cause, but essentially can be hypothesized by environmental factors, genetic factors, gut microbiota, as well as immune system dysfunction. So broadly speaking, inflammatory bowel disease, IBD, can be divided either Crohn's disease or ulcerative colitis in the majority of the cases. There are other subsets, lymphocytic predominant colitis or collagenous colitis. That is kind of small bit only of the IBD. Ulcerative colitis, they present very differently as opposed to Crohn's disease, but sometimes they can overlap. Typical patient with ulcerative colitis, they usually have a bloody diarrhea, chronic bloody diarrhea, stool frequency, over than 3, 4, 5 times per day. They are watery loose stool mixed with the blood. They got abdominal pain. They losing some weight, and they also have some of them might have the extra-intestinal manifestation, meaning that the symptoms outside the gut, for example, polyarthralgia, joint pain, back pain. They got red eyes. They got joint problems. So, or these are the manifestation outside the intestinal. And Crohn's disease, as opposed to ulcerative colitis, they presented slightly different way. They tend to get a crampy abdominal pain. They get a mucus discharge per rectum. Again, they can have a weight loss. Again, they can got the perianal, or if the disease affecting perianal area, They can got perianal abscess, recurrent perianal abscess. And to distinguish anatomically Crohn disease and ulcerative colitis, Crohn disease can affect anywhere from mouth to anus in the patchy way, but the inflammation is pretty deep. We call the transmural inflammation. But ulcerative colitis, typically they start distally from the rectum, and then they migrate proximally into the left side of the colon and also right side of the colon over the time. So they are the same umbrella of inflammatory bowel disease, but presentation slightly different. But some cases, the symptoms and signs are really overlapping. So we have to be carefully in terms of diagnostic value or giving diagnosis to the patient, either Crohn disease or ulcerative colitis. Nowadays, everywhere, any clinician in the world will use a basic history taking, clinical examination, endoscopy diagnostics with the tissue of the bowel that involves certain extent using radiological, either MR angiography or CT scan. And this combination of the biomarkers, in particular inflammatory markers like CRP, high platelet count, anemia, low albumin, these are chronically happen. These are the way that people diagnose the inflammatory bowel disease, either Crohn's or the ulcerative colitis, based on the tissue diagnosis. But in the near future, or even is going on now at the moment, many other aspects that we need to consider to be part of the component, not only as a diagnostic tool, perhaps also prognostic tool or therapeutic tool markers for patients with inflammatory bowel disease, using molecular signatures of certain markers, for example, certain molecular or microbiota signatures, for example, because various regions may have a different composition or different gut microbiota that predispose the patient to the inflammatory bowel disease. And multi-omic studies, proteomic, any form of advanced molecular biological technique to use so that we can stratify these patients specifically using all this multi-omics technology to say that these patients will require treatment A in order for us to be precisely treat the patient in this current era of precision medicine, so that all the biological, in particular therapy that are available to us, we can use carefully and selectively, appropriately to these patients based on the markers that we have from the stool, from the biopsy, or from the mathematical model, so that we want to get the highest response possible when we instituted the medicine for this patient. Number one, in the Asia-Pacific region, is someone coming with typical Crohn disease and ulcer in the ileocecal region between the cecum and the terminal ileum. Number one, we really have to exclude TB colitis or intestinal tuberculosis. We have to really 100% sure it is not TB colitis. So we confidently diagnose Crohn disease, and Crohn disease depends on the severity. Whether we want to use the Montreal classification or mild, moderate, severe diseases, or fistulating, and the fistula in the Crohn disease, perianal involvement, these are the factors that we need to take into account. And of course, the age and gender of the patient. Now, when treating Crohn disease, after the properly diagnosed Crohn disease, number one is the steroid, corticosteroid. These are the first line treatment for the corticosteroid therapy. It depends on the severity, either the patient needs intravenous or oral, depends on the clinical judgment. And the steroid therapy is a temporary therapy. It's not for the long term, because the steroid long term have a lot of adverse effect, diabetes, high blood pressure, osteoporosis, so on. So if the patient are moderate and severe after the steroid therapy, in Asia Pacific, we're still using what we call this stepping up therapy, for the next line is using immunomodulators. So these are the immunomodulators, in particular azathioprine or methotrexate, mostly azathioprine, will be used to help or to cease all the inflammation component for Crohn diseases. So the dose of the azathioprine usually up to 2.5 milligram per kilogram body weight. But we also have to be careful in terms of the adverse effect of the azathioprine. Either they got neutropenia, infection. So some centers check TPMT level or NUC15, but it depends on the resources and availability, because they will cost extra to the patient and to the institution, which is not widely used, particularly in Malaysia. So usually azathioprine will be given about 2 to 3 months or so, and to see any effect, any adverse effect. And if there's nothing happening or patient still in disease state, not improving, then we have to escalate using biological therapy. So biological therapy is a few options in Malaysia, for example. But of course, before starting biological therapy, any of them, we really have to exclude tuberculosis again. Even though there is no intestinal tuberculosis, we do, depends on the resources availability, the interferon gamma test, we do the chest x-ray, MEN2 test, and if you think that latent TB is there, we may need to be treated first, the latent TB. In some cases, we may need to do even a CT thorax or even a bronchoscopy to completely ensure that there is no tuberculosis anywhere. Then the options of biologics, for example, varies with the Big Brothers biologic established in the market back in 1998, which is anti-TNF treatment necrosis factor alpha, which is either infliximab, that using intravenously, or Adalimumab, which is fully humanized anti-TNF alpha using subcutaneously. And other agent also available is vedolizumab, which is anti-integrin targeting alpha-4 beta-7, and also ustekinumab or Stelara targeting IL-12, IL-23. So these are the biological weapon, I suppose, that can be used for patients with Crohn disease. However, if patients have Crohn disease, having strictures, mechanical strictures, coming with obstruction, for example, and there's not much inflammatory process, these patients require urgent or earlier surgical intervention, depending where is the involvement of the bowel. If the small bowel, then the patient may have a small bowel resection. If the patient has the perianal abscess or fistula, they may have a ceton. So cooperation or working together with colorectal surgeon, very important in some patients who will be very aggressively presented, not only the typical Crohn's, but also other form of disease, perianal abscess, fistulating diseases. So I think nowadays the management of Crohn disease involving multidisciplinary team approach, involving us as a gastroenterologist, but also colorectal surgeon, nutrition, dietitian, psychologists, and many other allied health professionals. So firstly, the research arena in the field of inflammatory bowel disease in Malaysia or Southeast Asia and Asia Pacific are still lacking. So the way that inflammatory bowel disease, either Crohn's or UC, disease behavior are different compared to in Europe or in North America. For example, ulcerative colitis is very easy to diagnose and to treat here, and the success rate is high, even not using biological agent. But Crohn disease over here, they are very aggressive, and then they need to be treated far sooner with biological agent. So I think at this moment of time, using various biological agent and also small molecule, perhaps let's say tocilizumab, which is very well approved by FDA for ulcerative colitis, give an option because they are tablets, oral tablet, which is very friendly to the patient. And I think the research arena to open the gate of different pathways that we can block in order to stop the progression of disease is still under intensely studied in many parts of the world. But from the Asia Pacific point of view, targeting TNF-alpha, alpha-4 beta-7, which is anti-integrin, and IL-12/23 are still the dominant players for biological therapy in Asia Pacific. It's a very real and practical question. So I think we have to understand, we all learn this from medical school, that 80% of the diagnosis comes from physical examination and the history of the patient. So if someone presented with a lot of GI symptoms and a lot of red flag signs, and weight loss, bloody diarrhea, I think the general practitioner or primary care physician must refer this patient to us to do further evaluation as soon as possible. In other words, mostly doing a colonoscopy examination for the diagnosis. However, sometimes in real practice, the patient may not have typical symptoms or signs like in the textbook. Most of them may be presented like mimicking infectious colitis, because infectious colitis are much more common than inflammatory bowel disease. But I think one has to use a clinical acumen and judgment and careful history and physical examination, and use not only the typical routine blood tests, full blood count, CRP or ESR or any other markers, but I think in the case that one has not really carefully make sure to refer or not, one has to use what we call the fecal calprotectin, the use of stool sample to check any evidence of intestinal inflammation. So if the symptoms are very vague and not very typical of IBD, and if you do the fecal calprotectin and the level is raised typically more than 50, that is the time that primary care physician or general practitioner should refer to patient to us to do further investigation, i.e. colonoscopy examination. So I think introduction of fecal calprotectin is a good markers. I don't think it's a new markers. Everybody used this for many years, but it's another markers to say that there is inflammation in the intestine for that patient, because in a very mild disease, other biomarkers, for example, CRP can be normal. But the combination of CRP and fecal calprotectin really gives something else. Could be diagnostic and also a prognostic of the patient when the patient has established inflammatory bowel disease. I think very important for patients to understand the major and the most frequent complication of inflammatory bowel disease, in particular ulcerative colitis, or to some extent Crohn disease affecting the large bowel or even the small bowel, is neoplasia or cancer. So various data in the past have shown that again and again, perhaps in the early years, maybe about 20, 30 years ago, the factors that contribute to the development of cancer are few. Number one is duration of the diseases. In other words, the longer duration, the higher the chance the patient to get colon cancer. So, for example, if you get a 10-year diseases, let's say ulcerative colitis involve the whole colon, after 10 years, you have probably got 1 to 2% chance higher than other people who don't have IBD to develop colon cancer. If you have 20 years, perhaps 2 to 4%. And if you get 30 years, then you can get around, let's say 8 to 10%. Now, bear in mind, these IBD patients or ulcerative colitis, they are diagnosed at a young age. So supposing the patient diagnosed at 20 years old, involving the colon, the whole colon, or we call pancolitis. So by the time they're 50 years old, they have the disease for 30 years already. So they must be carefully under surveillance. They must be checked up using colonoscopy and a chromoendoscopy or localized, or taking the biopsy at the place that we suspect the normal cells. because they have the high risk factor for development of cancer. Not only disease duration, but also the state of inflammation in the colon itself, meaning that the more the inflamed, the more the chances the patient to have a cancer. Because many studies have shown that 20 to 25% of any cancers nowadays in human beings arise from the chronic inflammation. So if I give you an example, if you get a reflux esophagitis, you can get Barrett's esophagus, and you can get esophageal adenocarcinoma. If you get a gastritis, atrophic gastritis, you can develop intestinal metaplasia, and you can develop gastric adenocarcinoma. The same thing if you get hepatitis or whatever cause from hepatitis B or C or fatty liver, hepatitis will drive to hepatocellular carcinoma. Similarly, for the ulcerative colitis, the more the intense inflammation, perhaps the faster the process of carcinogenesis happening. In other words, the chances to have a cancer much higher for patient with IBD to persistently have the chronic inflammation. And the risk would add more and more if the patient got family history of colon cancer, if the patient continues to smoke, for example, a concomitant disease of primary sclerosing cholangitis, which is not that common in here, in Asia Pacific. So these are the factors that actually predispose the patient with chronic neoplasia. And again, the relevant other factors in our society is also obesity, diabetes, metabolic syndrome. They also increase the chances to have a digestive tract cancer as well. So I think these patients, we really have to be carefully follow them up, even though they don't have the symptoms suggestive of cancer, a proper surveillance with appropriate timing of colonoscopy, preferably using chromoendoscopy, endoscopy to detect the abnormal mucosa and biopsy, and appropriately treated them if need to have a surgery in the case of multiple low-grade dysplasia detected in the colonic tissues or high-grade dysplasia. Patient may be warranted to have prophylactic surgery or pancreaticolectomy, for example. So I think we have to be very careful about these patients under our follow-up in the clinic.
Right, doctor.
So I think for the awareness of digestive health in globally, I think we should have always careful analyze every single patient walk into our clinic, whether this patient is a very urgent to be referred to us in the hospital for further investigation, or if this patient are having a benign condition. But if I want to pay particular attention to the commonest cancer for Malaysia men is colon cancer, and the second commonest cancer for women is also colon cancer. Perhaps we can encourage our colleagues, including myself, to advise the patient to undergo screening for colon cancer because colon cancer is treatable and also preventable. And these are the model of the cancer that can be screened well in advance before the disease or the cancer develops. So I think my whole message is we need to optimize the screening for colon cancer, as the colon cancer has become number 1 for Malaysian men and become number 2 for Malaysian women. This must be a national agenda for all of us to curb, to stop the incidence of colon cancer in our country.